Hello, this is Bonnie Jackson, and I would like to thank you for taking time to view my presentation, Compassion, Fatigue, and Vicarious Trauma Among Obstetric Nurses. This is for Nursing 874 Selected Studies in Nursing for Fort Hays State University. By its very definition, nursing is, quote, the promotion and optimization of health and abilities, prevention of illness and injury, alleviation of suffering through the diagnosis and treatment of human response, and advocacy in the care of individuals, families, communities, and populations, from the American Nurses Association. However, what is routinely forgotten and has become a much more prominent problem recently is that we are forgetting to take care of those who take care of others. From the Code of Ethics for Nurses, Provision 5 states, "The nurse owes the same duties to self as to others, including the responsibility to promote health and safety, preserve wholeness of character and integrity, maintain competence, and continue personal and professional growth." Burnout, compassion fatigue, and vicarious trauma are becoming more commonplace for nursing as a whole and beginning to be recognized in specific nursing areas. Nurses experiencing these problems suffer not only individually, but their ability to provide compassionate care suffers as well. The concepts of burnout and compassion fatigue were first introduced and recognized in nursing by C. Johnson in 1992 in her investigation of burnout in emergency room nurses. She identified nurses who had seemed to, quote, lost their ability to nurture. However, she did not formally define this concept or do any further research. The term compassion fatigue was adopted by Charles Figley in 1995 as a friendlier term for, quote, secondary traumatic stress disorder. Consequences of burnout, compassion fatigue, and vicarious trauma are just starting to be recognized in the nursing and medical field. However, previously, these phenomenon had been recognized and much research has been done and documented with social workers, mental health therapists, counselors, child protection workers, first responders, and clergy. Compassion fatigue has been defined as the natural consequent behaviors and emotions resulting from knowing about a traumatizing event experienced by a significant other, the stress resulting from helping or wanting to help a traumatized or suffering person. Charles Figley first used this term in 1995. However, until 2010, the concept was never defined within nursing practice. Researchers maintain that this oversight meant that the phenomenon was never explored, described, or explained in a manner that would have allowed nurses to identify compassion fatigue and then to combat its effect upon themselves and also nursing practice as a whole. The concept of compassion fatigue is one that is a state that evolves over time and is a progressive state of emotional unease. There are many symptoms of compassion fatigue, which we will address in the next slide. Nurses are especially vulnerable to compassion fatigue, as nurses are often with people at very critical points in their lives. The nurse becomes a partner rather than an observer in his or her patient's healthcare journey. The very nature of nursing via the empathetic therapeutic relationship and the conscious or unconscious engagement with patients and families can leave the boundaries of professionalism sometimes blurred. Also, there is no global recognition of the potentially negative impact of nurses' work, even though nurses witness trauma on a regular basis. Nurses are also unique in that we are not only first responders, but also sustained responders who are expected to provide ongoing care to highly vulnerable patients. This slide lists some of the various effects of compassion fatigue. Some of the physical signs can include absence of energy, accident proneness. Some of the emotional effects can also include a breakdown, apathy, and a desire to quit. Additionally, social aspects can include unresponsiveness, callousness, and even indifference towards patients. Holistic effects can include poor judgment, disinterest, lack of introspection, and disorderliness. This slide also comments on some of the spiritual aspects as well as additional aspects in all the different realms of a person. Vicarious trauma is defined as the negative transformation of the nurse's inner experience resulting from empathetic engagement with client's trauma material. The phenomenon of vicarious traumatization results in a permanent disruption of an individual's cognitive schema. There is research that using a constructivist self-development theory to explain the development of vicarious trauma and postulates that one's unique history of life experiences shapes how one will experience, interpret, and adapt to traumatic or highly stressful events. Subsequently, this theory suggests that vicarious trauma is unique to the individual. And in my research, this is the theory that I used as the supposition. Additionally, it is recognized that certain nurses, especially in acute care settings, are especially vulnerable to vicarious traumatization. After a review of research, between 40 and 85% of all helping professionals were found to have compassion fatigue and/or high rates of symptoms of trauma. Additionally, it is reported that nurses experience compassion fatigue and vicarious trauma appear to work in high-demand populations, such as in oncology, critical care, mental health, or ER. These places are often high-demand, intense, complex environments. Another research reported that compassion fatigue has been seen in oncology nurses, vascular nurses, forensic nurses, hospice, pediatric, as well as emergency and critical care nurses. However, the irony of this is that only one study has been done on this concept in the United States involving obstetric nurses. Gable, in 2012, conducted a mixed method study of compassion fatigue in labor and delivery nurses. In their study, 35% of the nurses scored 38 or higher on the STSS, indicating moderate to severe compassion fatigue. They postulated that the very nature of the relationship between the labor and delivery nurse and the pregnant patient can serve to increase the risk of emotional stress due to witnessing a traumatic birth. Unfortunately, awareness of these issues is not commonplace, especially in acute care settings such as hospitals. Further research in England has found that midwives received very little support within their hospital system and often felt that their feelings were overlooked or ignored. Many times, the midwives were told, consciously or unconsciously, that these symptoms were just something they had to deal with because it was a part of their job. Also, there are cultural and organizational taboos, specifically no-talk rules. Many times, these no-talk rules are unspoken and inferred. Feeling that one cannot talk about the experience or the aftermath of a traumatic event will only add to frustration, helplessness, lack of trust, and avoidance of solutions. So what are some of the consequences of burnout, vicarious trauma, and compassion fatigue? Researchers have noted that there is a correlation between burnout and feelings of negativity, increased work-life conflict, poorer relationships, increased absenteeism, and lower commitment and productivity. Furthermore, burnout can lead to increasing feelings of bitterness, contributing to a toxic work environment, perhaps violating patient boundaries, and making nurses more prone to clinical errors. Additionally, it is noted that nurses experiencing compassion fatigue had increased risks to patient safety, decreased nursing productivity, and decreased caregiver compassion. The organization can also suffer for loss of effectiveness and efficiency and a decrease in the quality of patient care. It has also been noted that unfulfilled commitment, excessive unplanned time off, blaming others, increased mistakes, and contributing to negative workplace morale are additional consequences of these phenomenon. Finally, it can be noted that sometimes these effects can have the nurse at such a place that they want to leave the nursing profession for good. This can cause a higher turnover rate for employers, increasing the cost to facilities, and also, as a bottom line, contributing to the continued nursing shortage. The purpose of this mixed methods study was to determine whether or not obstetric staff have experienced a traumatic event in the last year, determine what events obstetric staff perceive as traumatic, and determine ways to improve the support process for staff after traumatic events. This study will explore events that are specific to obstetric nurses and provide information about what events staff members feel are traumatic. Additionally, the findings can be used to increase support measures for staff following traumatic events. The word traumatic was defined as follows: emotionally disturbing or distressing, relating to or causing psychological trauma. This study was undertaken using an exploratory research design. This design intended to explore different events experienced by obstetric nurses and whether those events were perceived as traumatic. Participants were surveyed after being given the definition of traumatic to gain insight into situations, settings, and circumstances experienced by these nurses. This approach allowed the individual nurses to define for themselves what was traumatic. An original online survey was created to assess quantitative and qualitative data. A partial subset, 17 out of 66 questions, of the Compassion Satisfaction Fatigue Self-Test for Helpers by Figley in 1995 was also included in this survey. The survey had a total of 18 questions. The internal consistency reliability coefficient for the subset questions was 0.91. The internal consistency reliability coefficient for the remainder of the quantitative questions was 0.57. The survey was pre-tested with 5 individuals, and piloting of the survey was not performed. The sample subjects were staff members age 18 to 65 of all ethnicities employed as registered nurses, LPNs, secretarial staff, lactation staff, and patient care technicians currently employed at Stormont Vail in Topeka, Kansas, on the obstetrics unit known as the birthplace. This sample was chosen due to the familiarity of the unit by the study advisor, the ease of distribution, and the convenience of possible participants. After obtaining IRB approval from both Fort Hays State University, the director of the obstetric unit, and the research council at Stormont Vail, an information letter was emailed to all eligible participants, approximately 100, explaining the survey and inviting them to participate. Participation was completely voluntary and anonymous. The information letter contained a hyperlink to the survey on SurveyMonkey. Participants were given 1 week to complete the survey. 20 surveys were completed for an approximate 20% response rate. The data was analyzed using IBM SPSS statistical software version 23. Demographic data, including position such as LPN or RN, years of experience, and primary work area was collected. Quantitative data was determined on the incidence of traumatic events, type of event, effects of the event, and a total burnout risk score. Qualitative data was transcribed verbatim and then examined for content. The qualitative data was ascertaining the use of supports following a traumatic event and also suggestions the participants had for additional support services. This slide is the first slide showing some of the results of this study. 70% of participants had experienced a traumatic event or unexpected outcome in the past year. Participants identified stillbirth or neonatal death as the most common traumatic event, N is 15, followed by placental abruption at 12, shoulder dystocia and postpartum hemorrhage both had 10 experienced. Postpartum hemorrhage, as I said, was 10. A prolapsed umbilical cord was 7. And a newborn code was also at 7. This slide shows the results of whether or not experiencing those unexpected events were deemed traumatic by the nurses. Those experiencing a stillbirth or neonatal death, even though there were 15 participants who experienced those, only 47%, or approximately half, found that experience to be traumatic. However, the participants experiencing a newborn code, of which there were 7, 71% of those participants found it traumatic, leading us to see that newborn codes and stillbirth or neonatal death, even though there are differences in the frequency of these events, are the two most commonly identified as traumatic for these obstetric nurses. Other events were less traumatic, such as the shoulder dystocia, an obstetric hemorrhage, prolapsed cord, or a placental abruption. This slide shows some of the other events identified by nurses as unexpected or as they had experienced them, such as any type of delivery to a hysterectomy, a placental defect, such as a placenta accreta, DIC, which is a bleeding disorder, an eclamptic seizure, massive transfusion protocol, a medication error, patient misidentification, or a breast milk mix-up. All of these happened at much less frequency, and only one of these was defined as traumatic by the nurses completing the survey, and that was the massive transfusion protocol. This slide shows some of the effects those traumatic events had on the obstetric nurses. The most common effect was on their stress level, coming in at 64%, followed by sleep at 43%. Also of note, some of the other categories, such as work, coping ability, job performance, and mental state, are definitely present and suggest that even experiencing a traumatic event at work, the nurses are not necessarily able to separate their personal life from their professional life and do take the effects of these traumatic events home with them. This slide shows the risk for burnout per the Compassion Satisfaction Fatigue Self-Test for Helpers test by Figley, in which it showed 30% of the respondents scored moderate or high on the risk for burnout. The score of less than 36 was an extremely low risk. A score of 37 to 50 equaled moderate risk. 51 to 75 equals high risk, and 76 to 85 is extremely high risk. I've included this slide because we did a t-test on the scores both for the mean burnout score and the sum burnout score between participants who had or had not experienced a traumatic event in the last year. Although the data was not statistically significant between the two categories, they did demonstrate a noticeable difference just by looking at the mean and sum scores. This would be an area for additional research, as I think the small sample size contributed to the lack of statistical significance. Examination of qualitative data revealed that the majority of the participants were not aware of formal or informal support processes available after an event. Only 3 participants knew about the Employee Assistance Program. 5 were aware of debriefing as a strategy, and 6 participants spoke to colleagues on their own about the event. Additionally, only 1 participant who experienced a traumatic event received follow-up that they did not initiate. Some of the reasons given by participants as to why they did not utilize supports included: I did not realize that there were other options. The EAP is not easily accessible and not conducive to immediate assistance with traumatic events. Or I felt I had to deal with it personally, or resources were not readily available. One of the most compelling responses that I received on this survey was, quote, "I don't know. I did not feel as if anyone in the organization cared about how it affects the staff." This particular statement mirrors research findings by Rice and Worland about the lack of support in a hospital system and the nurse feelings being ignored or overlooked. Suggestions by participants on ways to improve workplace supports following an unexpected outcome or traumatic event include mock drills and codes for all areas of the unit, not just labor and delivery, supportive and non-judgmental colleagues, formal debriefing that takes place quickly and is led by someone not involved in the event, talking with peers, having the charge nurse and upper staff show and offer support, and having continued follow-up by colleagues and senior staff. Again, I put the comment that the nurse did not feel as if anyone in the organization cared about how it affected the staff. This was my experience as well after having a traumatic event, and I can tell you just how devastating it is. In my survey, 70% of participants experienced a traumatic event in the past year working on an obstetric unit. This high incident rate sheds valuable light on obstetric nursing as an area needing additional research and study involving burnout, compassion, fatigue, and vicarious trauma. The oversight of obstetric nurses suffering from compassion, fatigue, burnout, and vicarious trauma continues the climate of inadequate support and misconception that obstetrics is always a, quote, happy nursing area. Identification of the most commonly identified traumatic events allows management and colleagues to begin constructing workplace supports and assistance. Knowledge of the most common effects of traumatic events have on nurses can also assist workplace interventions or individual reflection and self-awareness. Additionally, noting that 30% of participants are at moderate or high risk of burnout can assist individuals and management to implement strategies of self-care as well as provide means of continued follow-up. Limitations of this study include the small sample size and use of a convenience sample for study. It is also possible that nurses who were experiencing compassion fatigue or vicarious trauma were more likely to respond and participate because the topic held personal meaning or interest to them. However, it is also possible that the more traumatized nurses may have not wanted to participate due to negative feelings and emotions that could happen by reliving the experience. Additional research is needed in this area, specifically looking at obstetric nursing and other variables that could influence these phenomenon. Perhaps looking at years of experience related to defining traumatic events could be one area of study. Implications and interventions for nursing practice begin with education and increasing awareness about burnout, compassion, fatigue, and vicarious trauma. It is suggested to begin with nurses themselves and educating about the vulnerability when caring for patients who are traumatized or suffering. Additionally, we can educate nursing students as well. This education can serve to empower nursing students with the correct and pertinent information as novices in the nursing field to help prevent the development and progression of these issues. Organizations such as hospitals can also offer continuing education programs aimed at symptom identification and additional coping strategies. The concepts of burnout, compassion fatigue, and vicarious trauma are beginning to have some great strides in nursing. As a profession, we are now tasked with increasing awareness through education and providing realistic help and assistance to nurses combating these problems. No longer can society, nursing, or medical establishments deny their existence and the effect they have on the nursing workforce. Additional attention and research is needed about these concepts, specifically in the obstetric nursing population. Increasing workplace awareness and support will benefit everyone involved, from patient to corporation. As the struggle to combat the ever-present nursing shortage continues, it is time to turn attention towards caring for the caregiver. I would like to conclude by thanking you so much for your time and attention during my presentation. The final slide is my reference slide. Thanks, everybody. Have a wonderful day.